Many a times we feel that, particularly those of us who work in the critical care setting, many a times we try to, in order to intervene a patient for the patient's benefit, for not doing harm to the patient, non-maleficence, what we do? We restrain the patient. We tie the patient's limb, okay, with the bedside. The intention is very noble, but then do we like it? Does the patient like it? Patient comfort and dignity must supersede clinical convenience. Clinicians are mandated to prioritize non-restrictive alternatives. So it is not just while we talk of clinical efficiency, we can restrict patients and to the extent violating their comfort zone. We must emphasize on the importance of patient's comfort. We must think of alternative care. The clinical scenario would explain this. An elderly patient with advanced dementia is restrained to prevent her from pulling out on an IV line for a urinary tract infection, okay, causing serious distress and bruising. The ethical conflict is tension between clinical safety and efficiency, which is related to the beneficence and non-maleficence on one hand, and the infliction of the patient's distress. So this has also been discussed in different way by Professor Mary in earlier sessions. Coming to another article of benefit versus harm, or as Dr. Russell has also pointed out about proportionality and not doing harm to the patient. Think of a clinical scenario when a terminal cancer patient is offered a novel experimental drug with a marginal survival benefit, but devastating toxicity. So the ethical conflict there, okay, is in pushing the boundaries of extension versus inflicting severe end-of-life suffering. Now, the ethical application here, it requires a holistic evaluation of quality versus quantity of life. Many times we feel we are doing a great job in cancer, terminal cancer patient, when we are trying to actually prolong life for one month or 4 months or 6 months. But those 1 or 2 or 6 months the patient is surviving, what is the quality of their life? As clinician, many a times that doesn't carry much value. So I think time has come, we have to think of making a balance, okay, this quality versus quantity of life balancing, in order to ensure interventions do not destroy holistic well-being. That also relates to patient's wish for the end of life, okay, how to embrace a respectful end of life situation. So the family members would like to prolong the life only. But for that, putting the patient in a ventilator without bothering to seek for the choice of the patient, whether the patient wants to spend the last few hours of his life, okay, surrounded by his near and dears at the comfort of home, or the patient wants to breathe his last, okay, in the critical care unit, okay, fitted with all different channels and needles and ventilators and all, and nobody knows when the patient is going to breathe his last. So these are also the situations that are troubling, that are disturbing the near and dear ones. Okay, after the patient has died, I have heard many sons and daughters, they lament that we did not have probably taken the right decision. We should have discussed with my father and respected his wish when he is going to, how he is going to embrace the end of his life. Okay, so these are the situations which there is nothing hard and fast yes or no to this kind of discourse or this kind of decision making, but this reflection, okay, that's what matters. The discourse itself is more important than the final determination or final decision. Coming to the Article 5, autonomy and individual responsibility, okay, clinicians must unconditionally respect a competent patient's bodily autonomy. Competent means he is competent to give consent, he is competent to appreciate the knowledge or the information that is shared with him or her, and then take an informed decision. Okay? So that is a competent patient. So his bodily autonomy, even if they fundamentally disagree with the clinical outcome, the scenario is like a competent means ability to determine or ability to decide what is good or not so good for himself. A 70-year-old patient refuses a life-saving blood transfusion due to deeply held religious beliefs. So what kind of decision we are going to take? The kind of ethical conflict here is the physician's ingrained duty to preserve life. Okay, as a physician, I feel I am committed to that, versus the patient's absolute right to self-determination. That's what is autonomy. So how are you going to balance that? So these are some of the areas where we need to ponder, think, discuss, engage in dialogue, and finally come to a joint decision. Coming to Article 6, informed consent, exceptions for direct benefit. Unconscious patient, there is an immediate threat to life, and then we presume a consent is there in the best interest of the patient. You don't wait for the consent. In that case, the caregiver almost becomes the patient's primary guardian. The caregiver has to play the third role, that of a guardian. Because if you wait for the consent for the family members, you are missing the train. So you take that presumed consent, do whatever is best as per your belief, and try to save the life. Consent is presumed based on acting in the patient's best interest, and concurrent efforts to locate family and directives must continue. And it is equally important, as Professor Mary has mentioned, document everything. So that is also important, because here is where you are at the interface of crossing the limit and what is acceptable by law or what is not acceptable. So you have to guard yourself also as a professional, but at the same time, at the supreme, priority has to be given to what is best for the patient as per your knowledge, belief, and understanding. The clinical scenario was an unconscious patient arrives in the emergency room following a severe car accident requiring immediate life-saving surgery. So it is done, most of the time. And the ethical conflict could be the inability to obtain explicit informed consent versus the urgent necessity of medical action. So usually we do it in a very mechanical way, because that is the way we have been also taught what is best for the patient. Go ahead, don't wait for the consent. But at the same time, as the whole world is asking for autonomy of the patient, we have to also think of that. And sometimes we say we can also think of a deferred consent concept. That is, you are deferring the consent until the point of time when the patient gains his competence to give consent, and then you say that this was the way, this was the situation, and this has been done to you. Or the family members arrive, then you have to talk to them. Coming to the Article 8, respect for human vulnerability and personal integrity. The clinical scenario is a researcher attempts to enroll nursing home residents with limited cognitive function. Limited cognitive function means not competent enough to consider and be informed, apply his mind and take a decision. So limited cognitive function. So you are expecting his enrollment into a study, patient coming to the hospital and talking to him whether he or she would be interested to enroll in the research. So there should be institutional safeguard, institutional policy, institutional SOPs for conducting research using patients or employing patients, supported decision making, and finally, most importantly, whether the patient is cognitively sound. If he is